Ketamine is known for producing a different type of anesthesia called dissociative anesthesia, which is a state marked by analgesia, amnesia, and a trance-like unresponsiveness. Clinically, it is used for induction of anesthesia, procedural sedation, and acute pain management. In recent years, it has also emerged as a treatment option for severe depression and other mental health conditions. Chemically, ketamine is a derivative of phencyclidine, which is an older anesthetic that is no longer used because of serious neuropsychiatric side effects. At the center of ketamine's structure is a cyclohexanone ring. This part of the molecule makes ketamine highly lipid-soluble, which allows it to cross the blood-brain barrier efficiently. That is why it has a rapid onset of action, usually within 30 to 60 seconds when given intravenously. Attached to that cyclohexanone ring is a chlorophenyl group. This component is essential for ketamine's activity at the NMDA receptor. It is mainly through NMDA receptor antagonism that ketamine produces its characteristic dissociative anesthesia. Ketamine also has a chiral center, which means it exists in two mirror image forms called enantiomers. These are known as S+ ketamine and R- ketamine. These mirror image molecules differ in how they interact with receptors in the brain. S+ ketamine has a stronger affinity for the NMDA receptor, which makes it more potent as both an anesthetic and an analgesic. On the other hand, R- ketamine is less potent at the NMDA receptor, but it is being studied for its longer-lasting antidepressant effects and for causing fewer dissociative symptoms. In clinical practice, the ketamine that is commonly used contains a racemic mixture. This means it includes a 50-50 blend of both the S+ and R- forms. Ketamine, in its pure form, is a white crystalline solid that appears as a fine powder. Due to its poor water solubility, it is not suitable for direct injection. To make it clinically usable, it is converted into a water-soluble hydrochloride salt by reacting with hydrochloric acid. This salt form, ketamine hydrochloride, is then dissolved in sterile water to produce a clear injectable solution, commonly available in concentrations of 10, 50, or 100 mg per milliliter. Commercial ketamine preparations typically include benzethonium chloride as a preservative. This solution is usually acidic, with a pH between 3.5 and 5.5. Because of its acidity, rapid intravenous injection may cause irritation to veins, so a slow push over 30 to 60 seconds is recommended. It should also not be mixed in the same syringe with alkaline drugs such as barbiturates, as this may lead to precipitation. Although the solution remains stable under standard conditions, the preservative may degrade once the vial is opened. For this reason, open vials should be used within a few days or according to institutional guidelines, and always in line with the manufacturer's recommendations. The absorption of ketamine depends on the route of administration. Intravenous injection provides 100% bioavailability, while intramuscular administration yields about 90%. Oral absorption is poor, around 20%, due to significant first-pass metabolism in the liver. Intranasal administration, which is commonly used for psychiatric indications, offers bioavailability between 30 and 50%. The focus of this video will be on the intravenous route. Once ketamine is in the blood or plasma, like most anesthetic agents, it is rapidly distributed to highly perfused organs, especially the brain, which is its primary site of action. This rapid distribution occurs because ketamine has high lipid solubility, allowing it to easily cross the blood-brain barrier. In addition, the brain receives a significant portion of cardiac output, which accelerates drug uptake. As a result, ketamine has a very fast onset of action, typically within 30 to 60 seconds. However, this initial effect is short-lived due to redistribution of the drug. After saturating the central nervous system, ketamine quickly leaves the brain and redistributes to tissues with lower blood flow, such as skeletal muscle and fat. This redistribution causes a rapid decline in brain concentration, even though the drug remains in the body. Other pharmacokinetic features also influence this distribution process. Only 10 to 30% of ketamine is bound to plasma proteins, which means that most of the drug is free to diffuse across tissues rather than remaining in the plasma. In pharmacological terms, ketamine has a high volume of distribution, meaning that it redistributes extensively into body tissues. Ketamine is primarily metabolized in the liver, mainly by the CYP3A4 enzyme, with CYP2B6 and CYP2C9 contributing to a lesser extent. The first major metabolic step is N-demethylation, which converts ketamine into norketamine, an active metabolite that retains about one-third of the parent drug's potency. Thus, part of ketamine's effect persists beyond the disappearance of the initial drug. This also means repeated or prolonged infusions can have cumulative effects due to the metabolite. Norketamine is then further metabolized through hydroxylation, forming compounds such as hydroxynorketamine isomers. While these hydroxylated forms are inactive as anesthetics, they may contribute to ketamine's antidepressant effects, especially in subanesthetic dosing. Following hydroxylation, the metabolites undergo conjugation reactions, primarily glucuronidation, which enhances their water solubility and facilitates renal excretion. A minor pathway also includes dehydration reactions, though these play a limited clinical role. Ketamine works by blocking NMDA receptors, which are found in many parts of the brain and spinal cord. These receptors are normally activated by excitatory neurotransmitters such as glutamate. When ketamine blocks these receptors, it stops the transmission of pain and other sensory signals. This is what gives ketamine its anesthetic, amnestic, and analgesic effects. Let's take a closer look at how NMDA receptors work. The NMDA receptor is a type of glutamate receptor found on nerve cells throughout the brain and spinal cord. Under normal resting conditions, its channel is blocked by a magnesium ion. When an electrical signal, called an action potential, reaches the end of a nerve cell, glutamate is released into the space between two neurons. Glutamate then binds to receptors on the next neuron, causing a slight change in the electrical charge. This small depolarization pushes the magnesium ion out of the channel. NMDA receptors also need a helper molecule, usually glycine, to fully activate. Once the channel is open, sodium and calcium flow into the neuron, and potassium flows out. This movement of ions excites the neuron and can lead to long-term effects such as memory formation, strengthening of nerve connections, and amplification of pain signals. Ketamine blocks these receptors, stopping this entire chain of events from taking place. In addition to blocking NMDA receptors, ketamine also has mild activity at opioid receptors, especially the mu and kappa subtypes. This adds to its pain-relieving effects. Ketamine also increases the levels of norepinephrine and serotonin by preventing their reuptake. This activates pain-inhibiting pathways in the nervous system and contributes not only to pain relief but also to its fast-acting antidepressant effects. Ketamine can also block voltage-gated sodium channels much like local anesthetics do, which helps in relieving nerve-related pain. It also inhibits nicotinic and muscarinic cholinergic receptors. This may play a part in its ability to relax the airways and influence the heart and blood vessels. In addition, ketamine reduces the release of certain inflammatory molecules, such as interleukin-6 and tumor necrosis factor alpha. This gives it anti-inflammatory properties, which may help lessen pain after surgery and could also contribute to its antidepressant effects. Ketamine produces a unique state known as dissociative anesthesia. In this state, patients may appear awake with their eyes open, and may show slow, involuntary eye movements or random limb movements. However, they remain completely unaware, pain-free, and unresponsive to painful stimulation. This effect comes from a functional disconnection between the thalamocortical and limbic systems in the brain. Breathing and protective airway reflexes are usually maintained. Ketamine induces profound analgesia, especially for somatic pain, by inhibiting thalamic and limbic pathways that mediate the emotional and affective components of pain perception. Its analgesic effects often outlast its hypnotic action due to active metabolites such as norketamine. Even at subanesthetic doses, ketamine can reduce postoperative pain and opioid requirements by enhancing descending inhibitory pathways and preventing central sensitization. Emergence phenomena are common and include vivid dreams, hallucinations, and agitation. These are reduced by benzodiazepines or propofol. Ketamine increases cerebral blood flow, cerebral metabolic rate, and intracranial pressure due to cerebral vasodilation. Traditionally, it was avoided in patients with raised ICP based on older studies in spontaneously breathing individuals, where CO2 levels were not controlled. However, more recent research in sedated and mechanically ventilated patients, including those with traumatic brain injury, has shown that ketamine does not significantly increase ICP and may even reduce it. With proper ventilation and controlled hyperventilation, ICP remains stable or improves. Ketamine's EEG shows active, high-frequency gamma wave activity instead of the usual suppression seen with other anesthetics. This happens because ketamine doesn't shut down the whole brain. Instead, it disrupts thalamocortical connections and sensory processing, making the brain look awake on EEG. This may limit the reliability of depth of anesthesia monitors. Additional CNS signs include mydriasis and nystagmus, reflecting increased sympathetic tone. Ketamine stimulates the sympathetic nervous system, causing the release of catecholamines like norepinephrine and epinephrine. This leads to increased heart rate, blood pressure, and cardiac output, making it useful in shock and hypovolemia. While ketamine has a direct myocardial depressant effect, this is usually masked by the stronger indirect stimulation. However, in catecholamine-depleted patients, for example in prolonged shock and heart failure, the depressant effect may become unmasked, causing hypotension or bradycardia. The sympathetic response can also be blunted by co-administering benzodiazepines and low-dose propofol. In such cases, ketamine should be used with caution, especially in patients on beta blockers or with severe coronary disease. Ketamine generally preserves breathing and airway reflexes, so most patients keep breathing on their own and can still cough or gag. Apnea is uncommon unless the dose is high or given too quickly, especially in children. It also helps open up the airways by relaxing bronchial muscles, which is useful in patients with asthma or bronchospasm. One issue to watch for is increased saliva and secretions, which can make airway management trickier, so it helps to anticipate that and consider using something like glycopyrrolate if needed. Ketamine slightly increases both intraocular pressure and intragastric pressure. It causes pupil dilation, known as mydriasis, and may produce nystagmus. It also increases skeletal muscle tone and activity, so the patient may exhibit occasional random movements or twitching. Hepatic and renal blood flow are generally preserved. Ketamine can mildly inhibit platelet aggregation, which may lead to a slight increase in bleeding, although this is usually not clinically significant. Ketamine is used for the induction of general anesthesia at a dose of 1 to 2 mg per kilogram given intravenously over 30 to 60 seconds. In adults premedicated with benzodiazepines or opioids, a lower dose of 0.5 to 1 mg per kilogram may be sufficient. For intramuscular use, the induction dose is 4 to 5 mg per kilogram. This route is helpful in children or in situations where intravenous access is difficult. For maintenance of anesthesia, ketamine is not used routinely but is helpful in certain situations. It is sometimes used in unstable patients like those in shock or trauma, during short procedures or as an add-on to other drugs to reduce pain and opioid use. It is given as an infusion at 15 to 50 micrograms per kilogram per minute along with nitrous oxide and oxygen. Extra bolus doses of 0.2 to 0.5 milligrams per kilogram can be given during painful parts of surgery. Muscle relaxants are often needed as ketamine does not fully relax muscles on its own. For procedural sedation, it is given in smaller doses. An intravenous bolus of 0.1 to 0.5 milligrams per kilogram is effective for minor procedures or as an adjunct to regional techniques. A higher dose of 4 to 5 milligrams per kilogram IM is used for sedation. For analgesia, a slow intravenous dose of 0.1 to 0.3 milligrams per kg is commonly used. Pain can be continued with a low-dose infusion of 0.1 to 0.3 milligrams per kg per hour to help reduce pain without making the patient unconscious. Alternatively, a small intramuscular dose of around 0.5 milligrams per kg can be used when intravenous access is not available. Such subanesthetic doses can also be used for analgesia in conditions like postoperative pain, cancer-related pain, and complex regional pain syndrome. As you can see, we don't have to remember the dose accurately, the doses gets reduced depending on the level of anesthesia, sedation, or pain relief we need. Ketamine has also been shown to produce rapid antidepressant effects when given at subanesthetic doses, typically 0.5 mg per kilogram infused over 40 minutes. This effect is outside of typical anesthesia practice but is increasingly relevant in multidisciplinary pain and psychiatric care. Oral and rectal administration are less common due to poor and variable absorption. Oral ketamine can be used in children for procedural sedation at doses of 3 to 10 mg per kilogram. Now, if we compare ketamine to other induction drugs, ketamine stands out because it supports blood pressure and heart rate instead of lowering them. This is especially important in patients who are in shock, trauma, or sepsis, where using agents like propofol or thiopental could cause a dangerous drop in blood pressure. In contrast, propofol causes vasodilation and cardiac depression, making it unsuitable for unstable patients. Etomidate is more stable than propofol but can suppress adrenal function, which may be harmful in septic patients over time. Ketamine also preserves breathing and airway reflexes, so the patient continues to breathe on their own. This is different from agents like propofol, thiopental, and midazolam, which commonly cause apnea and loss of protective airway reflexes. However, we should remember that it can increase airway secretions and might cause aspiration. Moreover, ketamine acts as a bronchodilator, making it especially helpful in patients with asthma or bronchospasm, where other agents could worsen respiratory function. Another advantage of ketamine is that it provides both sedation and pain relief. This is a major difference from other induction agents, which usually require an opioid for analgesia. For example, propofol and etomidate are hypnotics only, they do not reduce pain. In CNS, ketamine does increase intracranial pressure and muscle tone, which might be a concern in certain neurosurgical settings, though recent studies show it may still be safe if the patient is adequately ventilated and sedated. It can also cause emergence reactions, like hallucinations, especially in adults, though this can be reduced by combining it with a benzodiazepine like midazolam. Overall, ketamine is a highly versatile induction agent. It is the drug of choice in shock, asthma, and trauma, and it is safe in patients at risk of malignant hyperthermia or porphyria. Now, ketamine is not all sunshine and rainbows, it has some clear risks and situations where it should be avoided. It is absolutely contraindicated in patients with active psychosis or severe psychiatric illness as it can worsen hallucinations. In those with severe coronary artery disease or uncontrolled high blood pressure, ketamine's effect of increasing heart rate and blood pressure can be dangerous. It's also avoided in raised intracranial pressure or brain bleeding because it may raise ICP further, though newer evidence suggests this might not always be true if the patient is ventilated. In open globe eye injuries, ketamine can increase eye pressure and risk further damage. Naturally, if someone is allergic to ketamine or its preservatives, it should not be used. There are also relative contraindications where ketamine can be used, but only with caution. In glaucoma, ketamine raises pressure inside the eye by stimulating the nervous system, which can worsen the condition. In thyroid storm, it further speeds up the heart and raises blood pressure, increasing the risk of dangerous complications. In severe liver failure, the liver cannot break down ketamine properly, so the drug stays longer in the body, leading to prolonged effects and possible toxicity. During pregnancy, ketamine's safety isn't fully known, so it's used only when absolutely necessary. People with a history of substance abuse may react poorly or have a higher chance of misuse.